Hello and welcome from the Clinical Nurse Specialist Association of British Columbia, or CNS for short. We like to host regular webinars and networking events for the benefit of clinical nurse specialists from across BC, and really these events are for anyone with an interest in knowledge translation, quality improvement, or an interest in improving our healthcare system.
Welcome, everybody. Today we're meeting and we have some amazing speakers with some of our clinical nurse specialists that represented BC and Canada at the International Council of Nursing Conference on Advanced Practice Nursing from a CNS perspective. So our first presentation we have is from Tannis Andersen and from Michelle Tobin, who are presenting to us on For the Love of a Clinical Nurse Specialist, the value of a CNS role in a Canadian health authority.
We were really excited to be able to go to Scotland and present, and we had the opportunity to create a presentation on what the value of a CNS in a Canadian health authority within the interior health. To start with, interior health is situated in the traditional, ancestral, and unceded territories of the Dequel-Dene, the Ktunaxa, the Niqtlatmik, Secwépemc, Statlian, Syilx, and Chilcotin nations. And I get to live on the Syilx Nation here in Kelowna, British Columbia. Interior Health is one of 5 health authorities in BC, which you guys know at the conference. They, of course, didn't necessarily know. And Interior Health is consisting of urban, rural, and remote communities. And we're publicly serving approximately 834,000 people. So Michelle is the clinical nurse specialist for parenteral and transfusion practices, and I'm the CNS for primary care here in Interior Health. And we do not have any financial disclosures or conflicts of interest with the presentation in material. So clinical nurse specialists in Canada are considered advanced practice nurses with master's or doctoral preparation in nursing, extensive experience, knowledge, and skills in a clinical specialty. And that was developed in 2019 by the Clinical Nurse Association. And in interior health, we have 21 clinical nurse specialist positions, and I believe we're actually heading up to 23 just shortly. We have the CNS positions are regional across the health authority. They're embedded into the organization structure through clinical networks and programs, while they complement clinical administration and medical leadership. And CNSs are also supported by Interior Health through the Professional Practice Office under the Director of Advanced Practice Nursing. Interior Health advocates and supports the advanced practice nursing role of clinical nurse specialists, recognizing their value in their nursing leadership optimization, in the clinical expertise, the advancement of health care system transformation, and commitment to quality patient care. Interior Health advocates and supports advanced practice nursing roles that include nurse practitioners as well as clinical nurse specialists for system leadership optimization, healthcare transformation, and quality patient care. CNSs are encouraged in Interior Health to support schools of nursing, and we do hold adjunct professorship at different universities throughout the province. Michelle and I are both adjunct professors at the University of British Columbia, Okanagan, and we're providing supports for clinical and academic education. Michelle supports medical education through clinical lab and seminar instruction, mentoring master students, for example, policy development, and providing a micro-credential course in advanced vascular access. Tannis participates in nursing research, so I've been able to support UBCO with primary care nurses education, atrial fib, and team-based care. Also being able to support and mentor master's and doctoral students in primary care, as well as being able to create and offer an undergraduate, graduate primary care nursing course. CNSs in Interior Health also have affiliations with our professional associations, and Michelle and I are very honored to be part of the CNS ABC here, as well as myself being able to sit on the board for CNS ABC. And we got to advertise CNS ABC while we were there, and we had the wonderful opportunity to be able to pass out some pens and our business cards. The CNS is an interior health practice within the Pan-Canadian core competencies of clinical care, systems leadership, advancement of nursing practice, and evaluation and research. Within clinical care, CNSs provide care coordination, expert consultation and collaboration. Systems leadership, we support change management, improve care delivery, advocate for patient care, and influence nursing practice. Within advancement of nursing practice, we have the ability to develop evidence-informed programs, education policies, and clinical decision support tools that fall within our specialty within the health authority and post-secondary educations. Within evaluation and research, we hold a climate of clinical inquiry, support quality improvement projects, translate and apply research findings to frontline clinical staff. I'm going to provide an example of the valuable work that us CNSs are able to provide in interior health and a project that Michelle and I worked on for a year and a half. So it started with infusions in primary care, and there was always a question being asked about should we or should we not be providing infusions in primary care, so our IH primary care clinics, as well as our urgent and primary care centers. So we started following the IH strategic priorities, which are focused on equity and access, primary care optimization and practice standards, urgent primary care center implementation and operationalization, embedding person and family-centered care, and supporting our people. We embarked on this journey really looking at collaboration, expert consultation, improving care delivery, change management, influencing nursing practice, development of guidelines, and patient advocacy and education. So the journey was, like I said, over a year and a half long and began with the question, should infusions occur in primary care? We started with an environmental scan that revealed many varied practices. Clinics were providing infusions in the course of treatments, so for example, rehydration and migraine treatments. Clinics were providing infusions in communities where there was an absence or overcapacity in the home health and ambulatory care services, providing infusions to offload emergency departments, and we were providing multiple different types of infusions, including antimicrobials, immunotherapy like biologics, biosimilars, iron preparations, electrolytes, and hydration, to name a few. After completion of the environmental scan, I started a working group for a cross-organizational collaboration, and this working group included many, many partners. It was a very large working group. We had a patient partner, which was invaluable. A lot of the work around us providing infusions, as we kept saying, we wanted to be able to make sure that our patients had access and equity, as well as we were saying that there was a need to provide infusions to these patients in the community so they didn't have to go to other resources. We brought in pharmacy leadership, we brought in ethics, antimicrobial stewardship, we had frontline nursing staff, we had other clinical nurse specialists support like medication management, CNS. We had operational and strategic director support. We had the executive director for nurse practitioners available to us, and then of course our enabling partners like home health and ambulatory care. When the working group started, it became very clear that our question was should we or should we not provide infusions, but rather what is required at a site to safely provide infusions. So we reframed the issue. By rephrasing the issue, Michelle and I, with regular feedback from the working group, developed a guideline of considerations to determine rationale, feasibility, sustainability, and identify any other potential solutions to support safe, evidence-based, timely, and efficient access to IV infusions. The guideline included determination of appropriate for the primary care site. So what other primary care programs and services are available in the community? We determined that first dose IV antimicrobials as well as first dose immunotherapies were not safe to be given in a community setting where they were not co-located with hospital or emergency room. We determined that some of the medications required their own adverse event management. For example, iron infusions. When you're giving iron infusions, if you give individuals Benadryl for a mild allergic reaction, you can actually potentially worsen their symptoms. Transfusion of blood products are also not suitable to be given outside of acute care. Patient considerations that we brought into it were accessibility, safety, barriers, types of access devices. Peripheral venous access devices were preferred because of the amount of infusions that we potentially are giving central venous devices were going to be more difficult to be able to maintain competencies. Primary care siting considerations were included where the site was, where it was located, were they a freestanding building, were they co-located within a hospital or co-located next to an emergency department. We looked at nursing education and competencies. We also looked at infusion pumps for accreditation standards for primary care. We connected in with enabling partners, so making sure that pharmacy was supportive, biomed to look after the pumps, as well as IMIT to ensure that we had all the technical support that we required. We looked at all the clinical decision support tools, education and policies and procedures that were in interior health and across the province. And we identified 17 clinical decision support tools, education and competencies that our nursing staff needed to be able to follow and support. And we finalized the guideline to include a process for new sites to obtain approvals when initiating infusion services and a process for sites that were already providing infusion services. The guidelines went through many iterations with repeated validation through the working group, frontline staff, leadership, and invested partners before it was finalized. Once we finalized it, strategic and operational directors gave their approval, and then we published the guideline. We met with site leadership to ensure safe practices were being followed in assisting sites in moving away from dedicated infusion services. Some of our primary care sites were providing infusion services 3 days a week, and others were completely providing and were complete dedicated infusion practices, which meant we were no longer providing primary care services. So change management was required in education, and we provided education on the guidelines to all the staff, to the nurses, the physicians, nurse practitioner, team leads, and managers. And education was provided in group education as well as site-specific education, depending on the site's and staff's ability to attend sessions. An important piece of the education was on the why behind the considerations. And so when we published this handout, it was able to really speak to what the changes were and why we made the decisions we made and why the guidelines were put into place. And that was a huge help in change management and really in having everyone understand where we were going. And actually, it was really quite amazing because once we were able to answer questions, there really was no further pushback. With us putting all the limitations and the guidelines into place to ensure that we were providing safe infusions in primary care. The other big piece with this infusions document was just really showing that it was also a collaborative effort and that we had a large group. It wasn't just individuals saying yes or no, and that we were really looking at the whole picture. So overall outcome, we now have safe infusion practices implemented in primary care through standards, guidelines, clinical decision support tools, education, and competencies. We're making to ensure that infusions are connected to the reason for the visit and that we're not dedicated infusion services. We're also looking at the fact that, we don't want to be removing services for the community. And so if home health and ambulatory care are not able to have these services returned to them, then looking at potentially developing actual infusion clinics that are dedicated to support this. And overall, the significance of a regional CNS role is that we're able to leverage the full scope of the role. It allows for local and systemic healthcare advancement in nursing practice in all 4 competencies. We have a bonus within this is that we do love our positions. We have great retention and recruitment into our advanced practice nursing roles. And overall, we have improved patient outcomes, standardization of evidence-based nursing practice, relationships and collaboration between portfolios and programs. And we also are able to support undergraduate and graduate advancement of nursing education. And then we'd really like to acknowledge Interior's help for supporting my attendance at the conference, as well as Kelowna General Hospital Foundation. And any questions?
I see Anne-Marie.
Yes, that was very cool. Thank you for sharing. I was curious whether there was any like follow-up survey from the clinics where this has been implemented. I imagine personally, if it was me, I would feel like a big sense of relief having standard guidelines to now follow in these kind of situations.
No, I haven't done any follow-up, specifically evaluation of it. I do know, though, that we had one clinic who wanted to start doing infusions, and so I went over the guidelines with them and was definitely able to support the manager in helping them work with their clinic. And then the clinics that were providing infusions, I met individually with them as well and was able to support them in deciding how or what they needed to do to implement continued safe infusions or to be able to move away from the infusions. And so I had really good responses informally back from them.
I have to say, Tannis, I'm absolutely amazed at the depth and the breadth of the work that you did and just in awe of the team you were able to pull around you to engage in this. Like it's pretty incredible that you were able to get all of those folks all working together to support this and to do it in such a thoughtful way based on what the best evidence is out there and like the fact that you're looking at what is appropriate in primary care, what is not, and why would that not be? Yeah, it's pretty amazing work. Congratulations.
Thank you. And Michelle was a huge help because I could do a lot of the work in the organization and the documents, but I certainly needed her content expertise for knowledge in the whole infusions and in processes. And so she was instrumental in getting this across the finish line.
And it's evident in your presentation that you were really thoughtful about articulating the value of the CNS throughout this process, which is, I think, is something we could all learn from in future projects we do, because it's so very clear and it's so helpful to see that actually laid out so clearly.
Mm-hmm.
I love it.
It really was like when I got home, I was like, you know, it really was triple value. Like we're providing value to the healthcare system. Our health authority supports the value of the CNSs, and then we definitely value our positions. So it really fit well within the theme of the conference.
Just absolutely amazing work. Please do. Oh, Michelle, you are online. Thank you, Michelle, for all your contribution to this work. Was there anything you wanted to say?
No, I'm here. Like I said, I wasn't, or as Tannis said, I wasn't able to go to Scotland, so I've really let her take the reins on this because I was excited to see the presentation, how she would have done it in Scotland. So that's why I didn't jump in today. But yeah, like what was already said, where we collaborated to present and felt we had a great topic was really utilizing the scope of various CNSs and really leveraging that advanced nursing knowledge. So this project really did that for us and showcased that well, I think. So yeah, but I'm here. Yeah.
Thank you so much. Amazing work to both of you and pulling it all together and being able to present and showcase this work in Scotland for that International Council of Nurses is amazing. So thank you both for that.
Thank you for joining us. If you would like to learn more about our association, please visit our website at www.cnsabc.ca